Ladies and gentlemen, thank you very much for bearing with us for that technical interruption. We will now resume in about a minute. We have all our speakers back online po, and we'll begin. Miss Mikey, we can begin po in in uh, 30 seconds. Again, Miss Mikey.
Welcome back and good morning again, everyone. We apologize for that technical delay. We will now proceed to the second presenter today. For today, we will be joined by Dr. Johanna Rose H. Velasquez. Dr. Velasquez is currently an independent health researcher, and she will present her study entitled Strengthening Urban Primary Healthcare Service Delivery through the Use of E-Health Programs in China, Nepal, and the Philippines. This is also called the Super Study. Good morning and welcome to the webinar, Dr. Velasquez.
Good morning.
Good morning. Ladies and gentlemen, let's give the floor to Dr. Velasquez.
Good morning, everyone. On behalf of our lead investigator, Dr. Leah Palileo Villanueva, we would like to present preliminary findings and highlights of the local experience for our study, Strengthening Urban Primary Healthcare Service Delivery through the use of e-health programs in China, Nepal, Peru, Kenya, and the Philippines, or the Super Study. So for this morning, we would like to provide you an overview of what the study is all about, our key findings, focusing on three important key findings in the study, as well as our recommendations based on these findings. So what is evident among what has happened now is that we have come to recognize that with the COVID-19 pandemic, it has transformed our day-to-day lives and has challenged us to adapt to these changes. This forum alone is a testament on how the internet has become an invaluable medium for information dissemination and collaboration among us individuals and our institutions. The role of information and communication technologies transcends beyond these daily interactions. WHO has long recognized that e-health, or the use of ICT for health, as one of the enabling strategic tools that can address disparities in service delivery. It can strengthen local health system and support and facilitate the achievement of the UHC goals. In a broadest sense, e-health is concerned with improving the flow of information through electronic means to support and facilitate the delivery of quality and responsive health services. So we have recognized that the e-health has potential to achieve universal health coverage, specifically now that I think we can draw on from what Dr. Dance has told us. The use of e-health was prominent in their primary care studies. So this diagram shows us that there are currently gaps in the achievement of our health system goals. It with response to affordability, quality, and coverage of care for provision of health services. And the digital health interventions, evidence-based digital health interventions can address these gaps. So specifically focusing on health service delivery, especially in low middle income countries, we have recognized that e-health has the potential to improve quality of care in terms of decision making. One of it is through the use of mobile apps, as mentioned by Dr. Dance, the use of up-to-date or medical applications for health, extending the scope and reach of services through telemedicine. It can also help in reaching difficult to reach populations and geographical divides. So especially in geographically isolated and disadvantaged areas. It can also help in achieving cost-effective service delivery. So what we have come to recognize was that although we recognize that there is e-health has the potential to improve service delivery, utilization in the low middle income countries there is limited evidence regarding its impact. This is why we did the super study. The super study is a collaboration between the Asia Pacific Observatory on Health System Policies and the five countries, China, Nepal, Kenya, and Peru. For the local study, our partners are DOST and DOH, DOST PCHRD and DOH, University of the Philippines, and the Asia Pacific Evidence-Based Healthcare. And our main funding agency is DOST PCHRD. So what is the study all about? So the study is it is an exploratory study that we wanted to evaluate the utilization and implementation of e-health in the local health system, particularly focusing on perceptions, barriers, and enablers. So what we did was the study was a two-phase study. Two-phase. First, we did a literature and policy review of existing policies in all five countries. And then from there, the phase two of the study included key informant interviews from where we did key informant and interviews from experts, patient, and healthcare workers. So what first key informant interviews were where we included policymakers from national, regional, and local levels. We also interviewed members of the academe and e-health providers, NGOs were also included in the study. We also did a facility-based interview for both public and private healthcare providers. So we interviewed patients, healthcare workers, health administrators in both public and private facilities in Metro Manila. The focus of the study was on urban areas. And for the Philippine study, we were able to include a total of 58 participants from NCR. So this is divided among private and public health providers. So what are the results of the study? So first, the common features in all countries. I will be tackling each one more in detail in the Philippines in the local study, but I just would like to highlight some common features that we've seen in all countries regarding e-health implementation. So for example, in across all countries, we've recognized that one of the barriers was that there are policy gaps or lack of policy regulations for e-health. So majority of the countries included in the study had existing policies for e-health, mostly focus on strengthening initiation of the programs or in support of e-health. But what was lacking was that there was limited policies tackling on regulations and interoperability. So the sustainability of the e-health implementation was not clearly defined in the policies that are existing in all of these countries. What we've also recognized was that an important barrier across all countries, was the lack of cross-sectoral support and communications. For example, in China, one of the problems was that in one city alone, they had 18 e-health providers. And these 18 e-health providers have different formats or different e-health applications that were not interoperable with each other. So this has led to lack of communication interoperability of the existing e-health interventions. What we've also come up was that one of the facilitators for the implementation of e-health pertains to importance of people support and acceptance and motivation and incentives for health workers and their patients. For example, in Kenya, in Kenya and Nepal, they have a system wherein the follow-up of patients from, for example, from a primary care facility, when they refer patients to a tertiary facility or a hospital, what happens is that there is the follow-up can be done through the primary care facility by way of proper endorsement from the hospital level to the primary care levels through a telemedicine, meaning the patients are properly endorsed from the tertiary facility to the primary care facilities, and the communication, it's between the healthcare providers and not through the patient. So what happens is that um, the patients need not follow up the the tertiary facility as often as they need to, but can be done in the primary care level. So what it does is that it reduces the out-of-pocket cost for the patient, specifically transportation costs of going to the hospital, because all of the follow-up and can be done in their primary care level. So this uptake is important because as patients recognize that that e-health has a value to them and supports their needs, the uptake is patients are able to uptake support the system. So they're more willing to accept the interventions, the e-health interventions provided. So here, other facilitators include political support, technological availability will be highlighted in the local study. So this slide shows us the key challenges of e-health implementation that we have identified in public health facilities. So there are four key areas that we have recognized and we've grouped them together. So current challenges are, of course, is one major challenge is an enabling ICT environment. Topmost of the respondents' answers pertain to problems on software, hardware issues, bugs, slow loading time of the existing e-health applications within their health facilities or health centers. There's also unstable internet connection, which is prominent across all facilities in the public health area. What we've recognized is that availability of the e-health interventions is not sufficient. It should be the reliability and stability of the connection, the software and hardware should be should be available in order for it to be functional for the health system, for the local health centers. What we've also recognized was that the user design and applicability is not um, very staff friendly, or they not fully answer what is happening in the local health system and the local health center. Drawing on from Dr. Dan's presentation, he mentioned that what they use, the electronic health record, is a reflection of what is the workflow in the health centers. Most of the participants mentioned that the interface of the current e-health records that they've been using is very different from what is actually happening in their workflow or in their interaction with the patients. This is strongly related to this, if you can see the right side of which is integration to workflow. A lot of the participants of the health in the health centers mentioned that there is resistance to acceptance of using e-health in the workplace. So we tried to analyze what is the reason behind this resistance, and most of the healthcare workers mentioned that it is the technical comfort or acceptability of the new system that they have to use, because the resistance is not because they don't want to use the new system, but rather their the acceptability is because of their technical literacy, meaning how their knowledge in the use of the system. So what they've also mentioned is that redundancy of task. So they have to shift from paper-based reports, and then at the same time they need to encode these files online. So this redundancy of tasks leads to competing priorities since they have to perform other tasks beyond encoding, such as, for example, immunization, day-to-day interactions with patients. This additional burden for them of doing the paper task as well as doing the online encoding can has led to difficulty of managing their time. So it all affects motivation and acceptance to accept the e-health applications within their centers. So it is not fully integrated to their workflow. In the macro level, we've also noted that leadership and governance, given that most of the applications need to be um, supported by the current leaders in the local health system and needed to be funded by them, the initial acceptance is is key to uptake. So what we've noticed was that if the leaders are not um, fully supporting the e-health interventions that were implemented in the area, sustainability is questioned. So also what happens is that most of the time there are also competing interests. So for example, um, e-health becomes a second priority if other not only health related um, problems or priorities comes into play. So the importance of buy-in of the technologies is an important reason why e-health implementation remains remains a challenge for especially in the local health system. Next is standards and interoperability. As what we have come to recognize is that each facility, each local health system has their own e-health applications. And the problem is that e-health providers, as of the moment, are um, not interoperable, meaning they're fragmented and cannot be used because they're using different formats. What happens, for example, is even in a patient who will just go to another local health center if he decides to move his place of residence, he will not be able to take the same record with him. So what happens is that the record just stays with the same facility and they're not able to use it after they leave that facility. So the system becomes unusable for them. Also, we have recognized that because there are different providers, there are also competition and um, different interests, and there is lack of regulations between different e-health providers in the current system. There's also lack of public and private partnership between the two. So these four gaps, four key areas are important later on as we discuss our recommendations. So we also looked into e-health implementation in private primary healthcare facilities and why and how it works for them and also what we can learn from them. What we've recognized is that in private e-health facilities, the e-health is seamlessly integrated to their service delivery, meaning from initiation from patient queuing, it is already used. For example, registration of patients, consultation, and um, uh, of
Mikey, excuse me. Doc Jonah, we apologize. No, I think your audio is coming in and out. Ma'am Jonah, could you please turn off your camera for now just to check your connection? Miss Mikey?
Yes, Sir GP.
Yes, ma'am. I think Ma'am Jonah is having a problem. So we'll wait if Ma'am Jonah
Hello?
is
Hello?
coming. Ma'am
Ayan, hello?
Jonah, you're back. Sige ma'am, thank you po. Better
Better.
po. Please, last 2 minutes
Okay,
tayo ma'am.
sige.
Thank you.
Okay. So, So what are our key recommendations? So our key recommendation is again to focus on infrastructure investment. So still on good internet connectivity, providing software and hardware that is sustainable and available to to all e-health providers. We also recognize that there should be inclusion and participation of target end user in the e-health design and development of any e-health applications. What we've come to realize in the study was that majority of the e-health applications need to be designed in a bottom up approach wherein target end users are part of the design of the overall e-health applications that will be utilized. So it's important to invest on proper to look into political support, not only with the leaders, but also policies that support e-health implementation. And what we've come to focusing now on harmonization and standardization. This is a main factor for e-health implementation in the facility. What we've recognized is that e-health is still fragmented in our country. E-health is still fragmented because of the competing interests of different providers, and there is the at the same time the developers and the regulators are almost the same. So this can affect how it is implemented as well. So harmonization and standardization is very important to ensure the sustainability of the application, especially in the use in the local health system. So pre-priority recommendation is four, invest in infrastructure to create an enabling ICT environment, accelerate harmonization and interoperability, push for support in legislation, and increase collaboration with the private sector. With that, thank you very much.
Thank you very much, Dr. Velasquez. Now we will go to Dr. De Guzman's reaction for the second study. Again, Dr. De Guzman will not be is not available to join us today, but she has sent her reaction. So Dr. De Guzman writes, on behalf of the Provincial Officers Association of the Philippines under the leadership of President Dr. Normando Legaspi, who just retired last August of this year, and as Vice President of the POHAP Luzon Cluster, we would like to sincerely express our gratitude for your invitation as panelists on this 18th National Health Research Forum for Action, Session 2. The Provincial Health Officers of the Philippines recognizes e-health as a major component of in the universal healthcare. E-health is an important instrument of patient information, helping providers more effectively diagnose individuals in such a way of reducing medical errors and providing safer and convenient care. In an emerging field, in the intersection of medical informatics and public health, referring to health services and information delivered or enhanced through the internet and related technologies. In other provinces, e-health system is already in place in selected LGUs. An orientation was conducted to certain barangay health workers on the identification and management of common illnesses were already completed. The e-health technology was introduced in the province of Pangasinan sometime in 2016. This is called the Wireless Access for Health from USAID Luzon Health. It brought together process management innovation and innovative wireless, mobile, and digital telecommunications technologies to create a clinic-centered health information platform. EHATID from DOST Ateneo de Manila University, on the other hand, is a health information system which aims to support LGUs with the use of an electronic medical record or EMR mobile application that generates report for the checkup and field health service information. Lastly, iClinicsys from the Department of Health provides a systematic way to manage patient records and generate standardized reporting requirements both at the local and national level. In April 2016, PHO organized its monitoring team to assist LGUs in using the eHealth system. The eHealth system is a good health information platform that aims to ease the task of health workers of managing client information compatible with standard DOH recording and reporting requirements. When the new system was introduced, there were initial resistance from some LGUs due to various reasons such as ICT and manpower readiness and LGU support. But in some LGUs with strong political support, they readily embraced the system. However, not all those who implemented the system were able to sustain when the project support ended because there were no sustainability plans in place. Another problem that was encountered during the implementation is a lack of an e-health planning and mapping in the province to ensure proper management of the various e-health systems in the province. Now let's go to strengths. E-health system features online and offline features. It's user friendly. It's easy and fast. There's easy and faster retrieval of patient information, and of course, paperless transaction. Support to some LGUs and other stakeholders on e-health. Willingness of healthcare workers to learn new technology. Technical system support from the Department of Health and other partners. Organized e-health team at the RHU level. Dedicated PHO e-health monitoring team. Not all health facilities were ready to sustain the system when the technical support from partners ended. Limited support of some LGUs for ICT improvement, unstable internet connection in far-flung barangays, fluctuating electrical supplies in some areas, especially GIDA areas, technical discomfort of healthcare workers due to shift from manual to electronic, limited technical know-how on ICT, and the aging population. Other weaknesses also include DOH technical support is not sustained. There's duplication of tasks. Healthcare workers are still required to accomplish target client list and other DOH FHSIS recording and reporting forms. There's also limited DOH programs that are included in the system. So challenges of the e-health system includes political buy-in and support, investment in ICT equipment, and improvement in manpower capability. Interoperability of the system between PHO, hospital, and rural health units to harmonize public health data, reports, surveillance, and referrals. There's also strong public and private collaboration. There should also be strong public and private collaboration and improvement of manpower capability, including hiring of IT personnel and training of healthcare workers, especially for the more senior ones. Strong internet connection is also a challenge. Data protection and privacy, it has to be a hack-free system. implementation of data quality checks, and problems with PhilHealth claims. So for future plans, ICT mapping of all health facilities, both public and private, to determine e-health capability and available resources. Upgrading of ICT capability of provincially owned government hospitals, and in-depth study to determine efficiency of health service delivery and patient satisfaction. And that is the end of Dr. De Guzman's reaction. We move
Uh,
on. Okay, we move on to the question and answer portion. I think Dr. Velasquez has some response to Dr. De Guzman's reaction.
okay. Dr. Leah Palileo, our
Ah,
lead investigator, can also
yes,
join in the conversation.
yes, I would like to invite Dr. Leah Palileo to enter the room now so she can also join in the question and answer portion.
Good morning, everyone. Hi, Mikey.
Thank you. Hi, Doc.
Joanne, should I react to Dr. De Guzman's reaction?
Yes, please, ma'am.
Yes. Thank you. Good morning, everyone. I'm Dr. Leah Palileo Villanueva. I'm the principal investigator for the Philippines for this study. I would like to first thank Joanna, for my co-investigator, for presenting the results and recommendations from our study. I would also like to thank the NHRFA for inviting us to present the study, and DOST PCHRD for funding the study through the IHEAD program. I would also like to thank Dr. De Guzman for her insights and reaction. It seems like what she said is quite consistent with the findings of our study. E-health is really crucial in pushing forward the universal health care, and is an important ingredient to ensuring proper coordination and integration of the health system, not only across different levels of care, hospital to barangay health centers, for example, but even across different service delivery networks, especially since the type of e-health applications can differ from one network to the other. It's important. I think what has come out is that political support is important, especially for sustainability. It seems that there are a lot of pilots of different e-health applications, whether it's to support service delivery, information systems, financing, etc. But sustainability has been a problem. And I think that was highlighted in Dr. De Guzman's reaction. Another thing that I saw that I think was consistent was the importance of interoperability, sustainability, and third would be support for the frontline workers. A lot of the e-health applications are being used by our barangay health workers, and we all know that they are volunteers. A lot of them are older, from the older population, so we need to capacitate them to increase their technical literacy. I also appreciate the recognition of Dr. De Guzman of the importance of involving the users in the design, as well as the importance of incentivizing the use of e-health through financing. So I think it's important to address the gaps in PhilHealth claims using the e-health application. So I think that her reaction validates the findings that we found in our study, even if the population or the areas covered by our study are of more limited scope. Thank you.
Thank you very much, Dr. Palileo. The audience is requesting for the part where the sound got distorted. They would like to know the results of the private e-health in private systems.
Okay, Joanna, would you want to present it, or should I present this part? Okay, so I don't know where. Okay, so
Problems with my audio, so you
okay,
can.
okay. So for the private health facility, the main finding or main difference that we found here, in contrast to the public health facilities, was that first, the e-health applications were really integrated into the workflow and the patient journey. So once a patient comes into the private health facility, the patient already experiences the benefits of e-health, from queuing to the use of the e-health record. So that is evident both in the patient experience and the healthcare worker experience, to integration of laboratory requests and prescription, as well as payment. So throughout the patient journey, there is that e-health support. So that's what we meant by integration of the service delivery. In terms of the design was really informed by the workflow. Again, by the patient journey and the workflow. And there was a constant consultation with the users about what works for them, what makes it easier for them, so as to avoid redundancy and duplication of work. There was ready access to technical support in case there were problems with the technology. No? There was, since this was a private endeavor, they could easily tell the people or the workers to use a particular e-health application system. So, and they use the same system across different branches of the clinic. So that helped with integration and sort of circumvented the interoperability problem. So they could communicate at least within that private health system. They also, since they used an in-house e-health service provider, so it was quite easy to troubleshoot problems, and they were able to integrate data protection and security features. So in the end, this resulted in higher patient satisfaction. The patients that we interviewed in these centers actually recognized which e-health applications were being used in those facilities, and also told us that these applications actually help facilitate their patient journey and improve efficiency of healthcare. The downside is that since it was a private endeavor, all these came with a cost, no? And a lot of the costs were really shouldered by the patient through out-of-pocket payments. So those were, in summary, the findings for the private facilities.
Thank you very much, Dr. Palileo Villanueva. We have questions from the chat box. The first one is, health is not a priority concern for most local chief executives. How do we address this?
I think that is something we recognize, and I think that has been shown not only in the Philippines but across the different countries that were included in the study. Political buy-in and political support is really crucial. How to do that? Really difficult to say. We really need to. Well, one way is to push for legislation. No? So, for example, now that the UHC bill has been passed, different LGUs are scrambling to try to implement it. So I think legislation is very important, including the supporting legislation for the UHC bill. That's one way. The other is really to just push it to our LGU chief executives. It's a difficult question to answer, and I really don't have clear answers for that.
Yes, Dr. Palileo. That question was from Mr. Eddie Ponyo. So another question here is, would you know how the other countries are using e-health to address the current COVID pandemic in their areas?
Okay, so for the other countries, what we've seen was that those with stronger primary care systems and had integrated e-health applications in their health system just used it the same way, no? So it helped with proper coordination, proper health records, census building, and also telemedicine was also used. No? So the other countries had a more advanced e-health uptake and utilization. So their e-health applications was not only limited to queuing or e-health records. So they had some telemedicine applications as well. However, having said that, the study was completed, at least for the international part, was completed before COVID came. So I'm just assuming that they would be using the existing e-health applications to respond to the COVID pandemic.
Thank you very much for that answer. Next question is from Lourdes Risa Yapchonko. With concern on technical comfort and literacy of health workers at the primary level in the use of health technology, what is the possibility of engaging separate person or team at the facility to manage information systems?
Again, that will really depend on the budget and the prioritization that is given to e-health uptake and utilization and ongoing implementation. Some health facilities do have dedicated people
For encoder.
to an encoder, etc., to really focus on the requirements of the e-health applications and on maintaining the e-health applications. But again, that is variable because the support and prioritization given by the chief executives and the LGUs vary.
Thank you, Doc. Last question. I don't know if you can answer this. This is directed to the Pangasinan LGU, but I'll read na rin. Now that we know the context, status, and challenges of a health information e-health system in an LGU, how much investment is needed, and how should LGUs plan and strategize a step-by-step process to make everything interconnected and well-sustained?
Investment wise, a lot. I don't know exactly how much, but a lot, not only in terms of financial investment, but also political investment, manpower investment. No, I think what is important is the recognition that the e-health can be like a backbone, not only for service delivery, but it's a supporting mechanism for the health system. So since it is foundational, at least to me, I think it is foundational. It would be worth a lot of investment in it. Now, in terms of cost, exact costs, numbers, I really don't know. I can't say. In two words, I think a lot, but I feel that that investment would be worthwhile.
Thank you very much. Thank you very much, Dr. Joanna Velasquez and Dr. Palileo Villanueva, for sharing your expertise with us today.
Thank you very much, everyone, and stay
Very
safe.
much.
Okay, let's move on to the third study. For this one, we will be joined by Dr. Noel Huban. Dr. Huban is currently a professor in the Department of Clinical Epidemiology in UP College of Medicine. Dr. Huban is also the principal investigator of the Social Innovation in Health Initiative Hub in UP Manila. Currently, he is a member of the Committee on the Structure, Organization, Monitoring, and Evaluation in the Philippine National Health Research System. Dr. Huban will present his study entitled Social Innovation in Health System. Let us all welcome to the webinar Dr. Noel Huban. Dr. Huban, the floor is yours. Okay, a few reminders while we're waiting for Dr. Huban. If you encountered problems during the webinar, lost connection, or did not finish it, links to the webinar display will be sent to your registered email address. To receive a certificate of completion, please take the quiz and answer the evaluation via the link which will be sent to your registered email address. Participants are only allowed to take the quiz once. You need to score 80% or higher to receive a certificate of completion. Otherwise, you will receive a certificate of attendance. If you only wish to receive a certificate of attendance, just go to the link that will be provided to you via email. The webinar quiz will only be available for the next 48 hours. After the quiz is closed, your certificates will be issued at a later date after the verification of scores. Okay, as a final reminder, please double check your email address during the registration. Incorrect email addresses will not receive related announcements. Okay, I think Dr. Huban is ready to present his study on social innovations in healthcare. Dr. Huban, the floor is yours.
I might.
Ayan. Welcome, Dr. Huban, to the webinar. The floor is yours po. Okay, while waiting for Dr. Huban's audio to be fixed, a few more announcements. The National Health Research Forum for Action 2020 invites you to its upcoming webinar sessions. Next month, October 6th and 7th, at exactly 1 p.m. to 4 p.m., we will have our third session entitled Ensuring Continuity of Health Service Delivery Amidst Public Health Emergencies. It is divided into two parts. Part 1 will focus on the human resources for health and health facilities, while the second part will be special populations, migrants and overseas Filipinos, elderly population, and children. In November, we will have the session in November 12 at exactly 9 to 12 noon. The fourth session is entitled Optimizing Financial Resources for UHC in Times of Pandemic. Our fifth and last session will be on the 15th of November from 9 to 12 noon. This is entitled COVID-19 Lessons and Ways Forward. To register, please visit the link bit.ly/18.enfra. Please be reminded that you need to register to all sessions that you wish to participate individually to be able to get a certificate. We hope to see you all there. Let me check if Dr. Huban is back. Dr. Huban?
Yan.
Dr. Huban?
Naririnig mo na ba ako?
Yes, Dr. Huban. Okay, you may start your presentation.
Okay. Okay. Pang-apat ko na pong good morning. Good morning, everyone. Thank you for inviting me to this National Health Research Forum. Mas madaling mag-attend, mahirap mag-speaker, but it's most welcome to share with you this morning the works that we have been doing so far. Next slide. So for this morning, this is the things that I want to discuss with you, the introduction on health system strengthening, on the overview of CHI as our project would be familiar with some of you. For the past 3 years, since 2017, we have been all around the Health Research Forum. And then what are the advocacy announcements that we had so far? Next slide. As we all know, healthcare is complex, doesn't end with the individual, with the things that are biologically happening in a person and the acquired positive or negative potentials that the person has. And it's not only the determinants of the health, it also involves the members of the family. That's why we have the social determinants of health. And that as well, you put the family and the individual in the context of an environment and the society. So to address the health needs of an individual, it's really a complex thing, and people need several armamentarium and has to deal with different stakeholders and actors in that aspect. Next slide. Such that you have the 6 building blocks that was expounded by WHO, and it tells us that to deliver a good health and improve the quality of health of the individual or of the health system, you have the different components, the service delivery components, the workforce, the information system, the medical products, which includes the vaccine and the medication. Financing was going to pay for that one, and the leadership and the governance for that one. So it's going to lead for that one. So that at the end, the overall goal that we have is an outcome is a responsive healthcare system that is social and financial protection of the individual and the family and in an efficient manner. So these ones, if you look at, there is already systematic reviews on what are the studies that have been done so far, which is just published 2019 by a group that was funded by DFID in UK. And they try to analyze what are the studies in the different building blocks that has been done so far, focusing on service delivery, the workforce, the information system, financing, and the leadership and governance. And what they found out, next slide, is that there's a major role of the communities that should be part when you look at all those innovations or those strengthening mechanism that we are trying to do and test in the different communities that we have, in the different components of the 6 building blocks. So to strengthen in health system strengthening, we must go back to the principles of Alma Ata and involve really the community in terms of the health strengthening systems or strategies that we are doing. Next slide. So that's what the people that's what the WHO in 2014 actually they brainstormed, and in that meeting they come up with the social innovations in health, because there are innovations and there are social innovations that has been there. The most common or most prominent that we know is the technological innovations, but the group of experts thought that there's social innovation that are focused in health. And what sets it apart from that, and they come up with a definition that the innovation is a novel solution. It can be a process, a product. It can be a market mechanism. It is created and implemented by a range of actors, so it's not only a sole actor implementing it. And it is in response to a health need within a geographical context. So most of the innovations are happening in a geographical context, meaning in a urban area, in a community, in a municipality. And these solutions has enabled the healthcare delivery to be more inclusive, affordable, and effective to the target population or to that community. Next slide. So what are the characteristics of social innovations? Definitely it starts with the stimulus that makes them work to address the problem that the individual or the communities are facing. Who are the actors within the community, within the family, and what are the institutions that are involved? What processes should be involved in this one? There should be inclusive participation, collaboration, and coordination with all the stakeholders. And there should be also a multi-level and collaborative governance. As we said, there's an interplay of the sectors. There are technical needs, economic, and political dimension. Next slide. Other characteristics of social innovations, aside that we want it to be effective, efficient, and sustainable, is that what are the outcomes? What are the systems that we need to change and how we should document them as well? And what are the changing relationship with the innovation? And with the innovation, was there empowerment that enhance the community to continue the innovation? And there is a need to measure the impact of the innovation. Does it improve the quality of life, the well-being, and the value to society as a whole? Next slide. One of the proponents of social innovation tried to summarize all of this in this diagram, that you have at the core the health need, which are person-centered and there's context-specific, and you address this one with the different players on the top of the pie. You have the social sector, the private sector, the public sector, and some voluntary sectors. And this is the challenge, is that to come up with a process, a product, a role or behavior change, market mechanism, a paradigm, or a policy change to address the innovation. And the innovation type must be inclusive, effective, and affordable, so that we come up with the outcomes, which is improved delivery of healthcare. Next slide. So one may see that SIH is a new lens to strengthen the local health system. It redefines community engagement as the key drivers, and it promotes better understanding of the contextual realities and how it contributes to the national efforts. Why they target the university during the initial phase of the social innovations in health, when they scout for country hubs, which are potential partners in social innovations and health initiative, because they recognize the role of the universities and how these universities were able to engage the future generations and the recent and the present generations in terms of their interaction with the policymakers, with the researchers, and as I said, with the students who will be in the future leading the countries in terms of healthcare. Next slide. So, social innovation really puts emphasis on the community engagement as the key drivers of the health strengthening, and it should be designed with the members of the community, as I have mentioned earlier, so that there is ownership of the community and they will support the innovations as well, or the change that we wanted to achieve for the improvement of the healthcare system. Next slide. During the first year of the Social Innovation Health Initiative in the country, we had a country call and we identified some social innovations in health. And one of these is the Inter-Island Boat Project. And I said there's a problem in the community, there's healthcare delivery in an island community. You need to connect the remote villages to the health centers and also build up on the capacity of the health centers in terms of as a birthing facility. And it took the leadership of the municipal health officer to recognize that, but also the help of the healthcare workers with the midwives, and also the support that she got from the NGOs who supported her initial needs for the boats, and also for the local government who passed a local ordinance to support the health service boat project, the Inter-Island Health Boat Project. And looking at that, they focus on service delivery, and the financing aspect was also tackled, because they come up with a system on how to finance. Like you have the boat, you need the gasoline, and you need the manpower as well. So they also linked with the boatmen that are there in the areas. And the outcomes was presented in some of the presentations before the Philippine National Health Research System Week, is the improvement in the facility-based um, deliveries of the community. So they don't have to bring the pregnant women back to the main islands for their delivery. Next slide. So this one is the 660 Everyday Family Health Plan. This was with in Puerto Princesa, because there was a problem before with the tricycle drivers, how to come up and how to pay for their requirements for field health. So what they come up is that they worked with them, and through the organization, they were able to come up with the 660 per day. So each driver or tricycle driver will just have to give it to their leaders. So the TODAS, and then they're the ones who are connecting with the field health offices in terms of getting the these payments for the field health insurance of the families of the tricycle drivers and operators. Next slide. The Seal of Health Governance, this was emphasizing on the role of the health leaders in terms of the social innovations. What this come up is that having a trained leader who understand the needs for a good governance in terms of health, and not just stamped for or things that are presented to him, was able to come up with a program wherein he challenged the communities, the barangays, in terms of how can you say to us that your community is better in terms of the program that and the outcomes of the program that the Department of Health or the municipal health is trying to give to the local people. So he come up with what are the statistics in your community, and he makes this a public information so that each of the communities and their leaders would know how do they fare in terms of vaccination, in terms of toilets, in terms of all these things, and everyone knows that your community is lagging, your community needs this, and these are the things that you have to discuss with your local constituents and how you as local leaders can improve on this one. And they give a certain form of incentives and awards for outstanding barangays every year who have reached a certain level of good seal of health governance in their communities. Next slide. Next slide. So what I was trying to point in this one is that when you do the innovations as well as you try to help strengthen the health systems, you have to identify which components that might be context specific, but you have to be integrative in the approach. Sometimes the innovator sees the solution in his perspective, and it says it times he doesn't recognize it. But the point is, we have to work it out, because some of the innovations are there in the communities are not being appreciated, or just perpetuating without really having us learn from the good things that they are doing in the community. Next slide. So this is the National Telehealth System. So I think this is telemedicine, so that to help the doctor to the barriers program, and also the community to for the doctor to the barrios to be able to access the expertise in the main centers for problems that they encounter in the field. So next slide. So the universities, I think I've mentioned this one. So what we have been doing so far, the universities, not only UP, but the rest of the members of the PNHRS, and probably non-members are doing their role in terms of providing knowledge and also coming up with engagement in the local settings, and they are part of the innovations that are happening right now in the country. Next slide. So this is the social innovation in health. This is funded by TBR, and it involves 13 countries right now. Some 5 in Africa. Southeast Asia is Philippines and Indonesia, and then Honduras and Colombia. That's the network, and these are the logo of the partner agencies and support agencies. Next slide. And what we focus for the Philippines is identify the social innovations. We enhance the capacity for research. So what we do is try to document, do case studies for the social innovations that we have identified so far. We connect and convince stakeholders because we know that the innovators or doing the innovators need support either from funding agencies and also from the experts in terms of issues on sustainability and replicability, and institutionalizing social innovation in health in our needs as healthcare practitioners or people who are doing the or health education in the country. So what you have here are the pictures wherein we awarded the social innovations during the first year, during the PCHRD anniversary. The second picture was trying to come up with a module. So we need a modules that we can share those modules with those interested parties. And then we convened stakeholders, and we had one summit with the innovators last year and one with the innovation support group. And the last one is the institutionalization of the social innovation in health award, which is the GCARC. Next slide. We can skip this one. So it's just tell us these are the things that we're doing. So this one is we wanted to help the innovators journey to support their needs in terms of access, training, and resource network. Also to have them, and the facilitating factors that they need are team competencies, strong leadership and performance management, external support of the stakeholders, funding and enabling environment, so that we come up with more innovations in the future. Next slide. It's just summarizing. I for one may not, it's not really a new lens because there are best practices before. I usually equate social innovations right now in health as the best practices years ago, which we have been promoting and discussing in National Health Research Forum. But we have to revisit what are those practices and what happens to them if they're still engaging in that best practices, or what went good and what went bad with those practices. Next slide. If you want to know more about social innovation in health, this is the link. Next slide. And this is the award that is being supported by WHO and PCHRD. This is a national award. We are just the secretariat for this one. Now it's the DOH and DOST with PCHRD who are giving the award, and the award has this looking for social innovations in health. It's named after Helia Castillo, who is a national scientist, who is a social scientist, and who is very much involved in social and the health research. And it has a cash prize, and you can look. This site tells you where to look for it, and we're looking at the regional. We went to the regions already in terms of coming up, looking for the innovations in their needs. Next slide. I think this is the last slide. Thank you for listening.
Thank you very much, Dr. Huban. We now open the floor for the reactor of the third study. Dr. Lester Sam Heroy is currently a consultant of WHO, UNICEF, DOH, Alliance for Improving Health Outcomes, Physicians for Peace Philippines, DOST, and PCHRD, to name a few. Welcome to the webinar, Dr. Heroy.
Thank you very much. Can you hear me?
Yes,
Well,
Dr. Heroy, we
okay,
can hear you
great.
loud and clear.
Yeah,
You can take the floor now.
okay, thank you very much. Thank you, Sir Noel, and thanks also to the earlier speakers. Actually, I was listening also to Dr. Danz, Dr. Velasquez, and Dr. Galileo. So thanks a lot. A few weeks ago, but I was discussing with a friend who told me that just about 8% now of innovations can actually usually actually continue. So it's like, okay, so it's kind of small, no? Pero we'll see. And I'm very happy also to provide reaction and my thoughts coming from the research and the slides that were presented by Dr. Huban. Um, I'm an avid student of history, so you will see that a lot of my comments and inputs I have lots of history, bits of history things, and I'm also coming from a perspective of from ideas to reality or from research to actual implementation. So I'll be coming from that. My reaction has six parts. So first three is more of bits of ideas as I'm thinking of what is social innovation and what is innovation all about, and some bits we can glean from history. So three things on the history part, and also three questions that I'm going to pose to maybe Dr. Noel, and maybe even for the audience to answer in themselves. So first three things, and bits of history of healthcare. So first thing, actually, healthcare has actually produced a lot of innovation in history. If you remember, maybe you watched the movie Gladiator, or maybe you have read and seen movies from the Bible. You can see that doctors, there were no hospitals at that time, and doctors actually just go to the rich houses, and yeah, so the doctors actually go to the rich, and they are called. During the Dark Ages, during the medieval period, that was when the hospitals actually came out, as popularized, as started by monks, Christian monks. And one particular group during the Crusaders was the Hospitallers of St. John, who actually developed the concept and services in hospitals during the Crusader times. So the flow from a doctor just going to homes, and then now doctors going to hospitals changed healthcare a lot, because all of a sudden a doctor can actually see like 20, 30, 50 patients in a day. And so they began to start categorizing, recording, analyzing different diseases, symptoms, and even treatment options. And so that started, the disease classification and services in hospitals. So healthcare actually has a lot of innovations, and it's one of the things usually when we think of innovation in healthcare or new ideas and thoughts is the shift from the four humors concept to the germ theory, where we have the germs, and then later on the start of antibiotics and so on. So this shift actually of thinking, thoughts, ideas, is actually an innovation in itself. And Dr. Huban mentioned that innovation is defined as products, practices, mechanisms. But I hope we don't forget that new ideas are actually, and new thoughts can actually be the start. And so I mentioned a while ago the Dark Ages, where there was crusaders and things like that. But the Roman law is also an innovation in itself, and that actually flourished during the Dark Ages. Even the concept of kings and nations versus the church was also an innovation and a new kind of thinking. And then eventually, during the Renaissance and so on, they developed the concept of the corporation, which also facilitated the idea of capitalism and market economy. And then later on, the ideas of democracy came about. So one important aspect of innovation I was thinking and gleaning from history is actually we put new words to things that are happening. So putting new words, even the words tropical medicine in the 19th century was created, which later on became public health, where most of us are right now. And later on, after the war, the terms primary health care came. And now the new concept, new actually in the 2000s and 2010s, is universal health care or universal health coverage. So these are actually new thoughts and new ideas that fostered innovation. Bits of history. We're trying to learn and glean, especially as we try to analyze. There was a question from Dr. Huban. How can these innovations actually be sustainable? So I'm trying to borrow experiences from arts, music, sports, and let's see if we can learn from these. So we know basketball, for example, soccer, the Olympics. Actually, these started only in the 20th century. And the dragon boat and the Muay Thai were actually just started in the late 19th century by a Thai king, Chulalongkorn. So you have behind these innovations are actually I don't know, maybe people who just worked them out and made them happen. And a very important and big thing also is Hollywood and showbiz. In 1910, there was no Hollywood and no showbiz. But how did people innovate on these? How did movies became so popular and so on? And so I think my time is running out, but I'm just leaving 3 questions. So number 1, who does the innovation? Why did they do it? What is their context? Actually, in history, we may call them the great or they are geniuses. And there was a slide from with a quote from Dr. Abiertas, invest on people. But who are these people that we need to invest on? Who are the innovators? And then the second question that I'm raising also to Dr. Huban and the audience is, who should fund and continue the innovation? So should the national governments fund this? Should private sector? Should leaders, political leaders, and so on? And there was a mention a lot of times this morning on enabling environment and the context. So again, it goes on to who should fund and sustain and continue the innovation. And I end with this last question: how effective? This last question is also inspired because the theme for today and the topic is on local strengthening. So how effective actually is decentralization, or how did decentralization create this context for innovation? And if it's local innovations, should it be DOH? Should it be DOST? Should it be private sector? Who should fund this? Should the funding and the sustainability comes from the pockets of individuals? When you go to see a basketball game or a soccer game, it's not national government who pays for it, but it's actually coming from the people's pockets. So, and people question decentralization and so on. But really, how is decentralization and now UHC and SDN creating a good context, a positive context for innovation? So that's it from my end. Thank you very much.
Thank you very much, Dr. Heroy. We will now open the floor to questions that were collated from the chat box raised by our online participants. So the first question is, okay, what roles do you suggest LGUs take to make social innovations for health projects in their localities more sustainable?
Mikey, come again? What roles?
What roles do you suggest LGUs take to make social innovations in health projects in their localities more sustainable?
I think as one of the examples that we have mentioned so far is the seal of health governance, wherein a good support coming from the local government. I think you have to sell it to your local leaders and become it also. If it's something that is being clamored by your constituents, the local leaders should take should listen to them and hopefully would support them. Also, try to be a part. Now, you have your budget, so if you put if you put really importance on health, you can really show it with the performance and your support for the innovations in your midst.
Thank you very much, Dr. Huba. We move on to the next question. I would like to ask you to react to Dr. Heroy's reaction first.
Ay, hindi ko inaral yung history. Sorry. Ang dami. Natawa ka dyan, Mikey. Ano kayo sabi mo?
I think...
Ano yung questions ni Lester? Ano? Sorry, yung meaning how... as I mentioned,
yes, sir. Yeah.
Lester, most of the innovation are happening right now, and it's not being recognized by people as an innovation. It is something they do because they feel that they need to do it to address their needs. At times, it takes somebody outside that environment to recognize it. That's why that's the role of I think, researchers or other policymakers or DOH to recognize those things. Kasi they do it because they need it. They want to improve their service. Now, the thing about sustainability is most of the innovators some of the innovators probably doesn't think that they need to scale it up. I want to retain it here, but something scaling up needs another skills. So we have to partner with other experts in that field. I, for one, cannot do all the thinking process for like the business part of it. It's not a part of our training as healthcare professionals, as doctors, but we become managers. And when we become managers, we have to address it. So we need another experts in our midst. So it becomes more collaborative, and it helps to gain the positive things that the innovators or you, the program managers, is doing. So we need to network. That's why in the social innovation in health work that we're doing, we're partnering with people in the business schools because they're the ones who knows this one. I will not I will sit with them and talk and listen, but I want the expert to be the one partnering with us. Doctors cannot solve everything.
Exactly. Yeah.
What's the next question?
Yeah, so the first question, sir, was who does the innovation? Parang what makes them do it? So you mentioned the need, usually in the context. The context. Yeah,
they felt the need. That's why they innovate. And when there is an available innovation for them, they use it. If not, they try to come up with solutions.
Right. And then Right, and then you mentioned, sir, the importance of collaborating with the business people, because the next question is who should fund and continue. So it's a thing on scaling up, providing an environment. Yeah, I gave an example of sports, for example. Somebody starts kicking a ball and it becomes soccer, but then coming from somebody just inventing soccer to making it a big blockbuster sport it's a different thing altogether. Yeah, and then the final question, sir, was what is the role or the importance of decentralization in supporting these innovations, local innovations, which I think you have answered naman a bit.
Yeah. Who funds this? I think that's why DOH and PCHRD are now coming up with the Hela Castillo Award. I'm not saying that they are the ones only who needs to fund this. Some business sector might be interested in these kinds of things.
Great.
At the global level, Bill and Melinda Gates has all of those. What they call this? Or what are their funded? they have this all the monies for seed grant for a small project for a pilot, and if
Right.
they add more money,
Yes.
so that it became sustainable. It's just something that probably is not popular with us because they are more concentrated in somewhere in Africa or somewhere in Latin America. I don't know if Bill and Melinda Gates are
Right. Right.
saying that this that's
Doctor
available, or they don't even have probably a country office there. I don't know.
Dr. Huban, one last question po.
Yes, yes,
Yeah, and since you already mentioned the funds and the grants, and then I'll go back to the who. So what's the strategy? I think you mentioned bits, but just to emphasize, what's
yeah.
the strategy of SciHi? Because the who is, it might be a few people or a few groups who have already started something. How to grow them. What's the
Yeah.
strategy of SciHi in that? Thank you.
Yeah, the strategy right now is finding out who they are right now. At the GCARC call, which is supported by DOH and PCHRD starting this, is now who are the people doing the innovations. The next step is uh, uh, get the or do case studies or so that we will know what are the good things and the bad things or the needs of these innovators in terms of sustainability and how to replicate this. And it us and those in the government uh, or the LGUs and would be informed on how they can uh, adapt and replicate these innovations in their own setting. The other one is really help the other partners that we have who are more into that aspect of, I said, the business model for it and issues on sustainability. As we're just doing the first part, the rest of the work for sustaining the social innovation is really with the help of our partners in the academe and in other sectors, the private sectors as well. We can make them popular and let those funding agencies or those foundations see that there are good things that are happening in our midst and them help them these innovators and help the community as well in having access to the innovations that they are doing. I hope that
Hello. Yeah, hello. Can I quick comment? Yes, sir.
yes,
Yeah, so sir, you are like a competition pala, no? Yung mga singing competition, celebrity
mas madali
competition.
pa. It's easier to
Yes,
sing, you know.
yes. And then you find the talent and then let the media and the
Yeah.
managers take care of it eventually.
Yes,
Thank you
that's
very
the
much
way.
po.
Thank you,
Yeah,
Lester.
thank you.
Thank you, Doc Lester. We have two more questions, Dr.
Yes, sir.
Huban.
Yes.
The first one is, what challenges do communities usually face when they are introduced to a social innovation for their health concerns? Is there usually resistance?
Usually, meaning, is it the community per se?
The question was for the community, yes.
Yeah, because well, new ideas is really something that you have to sell. If the people doesn't feel the need for it, it's hard. It's a hard sell thing for you. So you have at least, if you work with them early on and help them and ask their help probably in the realization of the innovation or realization that there is a problem, because if used on there is no problem, people will not probably respond to you. And because some are just contented with status quo, they do not see, like for example, if you tell the people there are people dying and this is the magnitude as compared to other communities and they're not exposed to it, how would you encourage them? It's really, you have to sell it to the community. At first, if you're a municipal health officer, you sell it also to your staff because you need their help. Aside from your staff, then you sell it to your local chief executives. It goes. I think that's the which it goes that way.
Yes, definitely. With any innovation, selling is really very important. For the last question, I'm not sure if Dr. Uban can answer this. Is social innovations for health included in the present NURA?
Nako, hindi ko na. What I can say, probably there's an innovation aspect in that one because I think the researcher was asking this because for you to be funded for research is something it should be in the NURA. But I think there's the NURA is crafted in such a way that there is a space for everything that we can think of. And Lester, do you have an answer on that on the NURA?
Yes,
The NURA or
actually,
NURA?
research innovation is included in the NURA. NURA has 7 or 6 areas, I think,
Yeah.
and one of them actually focuses on just innovation and research. So yes, thank you.
Thank you very much, Dr. Huban and Dr. Heroy. That's the end of this presentation. Thank you very much for giving us your time.
Okay, thank you, everyone. Have a nice day. Kanta
So,
tayo.
today's session, we had 4 presenters. Director Asuncion presentation on the integration of local health system into province-wide and citywide health system emphasized that standards of care are maintained, uh, should be maintained within the LGUs, and the delivery of care is delivered in an integrated and coordinated manner. Dr. Dan's presentation zeroed in on their experience in establishing primary care network, uh, their experience in how primary care networks can be established, especially the use of innovative actions, along with the issues and challenges that may be experienced when establishing primary care networks. The third presentation by Dr. Velasquez on the results of the super study highlighted facilitators and challenges of the e-health implementation in primary care facilities. We need to work on good internet connectivity, software and hardware, interoperability of e-health interventions, acceptability by stakeholders, especially of the patients, also being used among others. Finally, Dr. Huban gave us an insight on using social innovations for health system strengthening and how important the role of the community is in this endeavor. And of course, he also highlighted the importance of measuring the impact of any innovation. Okay, and that's the end of session 2. I would like to remind everyone to take the quiz and fill out the evaluation so you can get your certificates, and register to the next 5, 6 sessions of the next 3 sessions of the National Health Research Forum for Action on our 18th year. To ensure that you register properly for our webinars, here are some reminders. Okay. After filling up the form, please make sure to register to Webinar Jam to gain access to the webinar link. To do this, click the link provided for each session to register to the Webinar Jam. Once in the Webinar Jam, please click the register button seen at the bottom right corner of the page. Fill out the form and click register now. Please make sure and double check that your email address is correct. Wrong email addresses will not receive the link to the webinar. You will be provided a link to the webinar. Please take note of this and you will go to this link on the day of the webinar. After a few minutes, you will receive an email containing the webinar link and registration confirmation. You will also receive a notification via 24 hours before webinar and 15 minutes before the webinar live to remind you that we are about to start. Thank you very much, ladies and gentlemen. Thank you very much to our presenters, to our reactors, and of course, the audience who stayed with us despite the technical glitch. For questions and comments about the webinars or concerns about your certificate, please email NHRAFA2020@gmail.com. This has been Barbara Michelle de Guzman for the session 2 of the National Health Research Forum for Action. We hope to see you again in our future activities. Thank you very much.
Nasistress ka na ba? Nagpapanik o natatakot dahil sa COVID-19? Normal lang ang ganitong mga reaksyon sa ngayon. Pero may magagawa ka para mapagtagumpayan ang sitwasyon na ito. Ituloy lang ang pangangamusta sa mga kamag-anak at kaibigan gamit ang text, tawag, o video. Tiyakin na ang mga bata ay ligtas at nasa maayos na kalagayan. Kung ikaw ay nasa-stress na, huwag itong ibaling sa kanila. Tandaan, anuman ang iyong reaksyon ay maaaring makaapekto sa kanilang emosyon. Gawin sa bahay ang mga nakasanayan upang hindi mabagot o mabalisa sa panahong ito. Basta siguruhing protektado ka laban sa COVID-19. Magdala ng good vibes sa bahay. Sa wastong pag-iingat, ang virus hindi kakalat. COVID-19, kayang-kaya nating tapusin.